So today's topic is bladder cancers. We have already dealt with certain cancers like renal cancer, prostate cancer in the previous classes. Today we are going to deal with a very common cancer, particularly in this part of the country in Bengal, which is the bladder cancer. Something which is not that common in the Western countries, not that common even in India, but very common in Bengal. My voice is clear, na? Okay. So first of all, bladder cancer is a very common cancer, almost around 9th common cancer worldwide. What we need to understand, it's an old age cancer. Most of the urological cancers are old age cancers, but it can also be seen in the younger age group. It is an environmental cancer. Why we say so, we will be basically seeing in the next slides. And yes, it has a very strong association with the toxins present in the environment. So males are more affected than the females. Actually, the fact is that the most common cause of a bladder cancer is smoking. And it was thought earlier that the smoking is more common in males, but now the prevalence is also increasing in females as well. So males are although more affected because of the smoking, but also because of the environmental toxins. I am time and again saying what are the environmental toxins. So basically it is the aromatic amines, aromatic amines like the benzidines as well as the beta-naphthylamines. Where are we finding these environmental toxins? Those who are working in dye industries, those who are working in leather industries, those who are working in paint industries, those who are roadside construction workers, all these things, they are also exposed to lead, arsenic, etc. So all these environmental toxins are actually increasing the chances of bladder cancer. They are not smokers maybe, but they are involved ultimately to this environmental toxins. A very good thing about this cancer is that if a young gets this cancer, it has a very good prognosis. Normally a patient who is young and develops cancer has a worse prognosis. But this is one such cancer where if it is diagnosed early, it has a better prognosis with respect to diagnosed late. So we will be basically discussing about the etiologies. We always have this particular gradation. First, what are the causes? Second, what is the diagnosis? How to make it? How to stage the disease? And then ultimately, what is the treatment like? So first, etiology. Genetics always plays a very important role. Now we are not going into details of the genetics. Just remember these two names. One is N-acetylcysteine, which is NAT, and the other is the glutathione S transferase, which is the GTM. These are two very important MCQs which are asked, and we need to understand what does the NAT do. NAT actually is the one which detoxifies nitrosamines. Now what is nitrosamines? It is something. Nitrosamine is basically a bladder carcinogen. So if it is detoxifying that, it will basically prevent bladder cancer formation. So what is happening if the NAT is getting altered, genetically altered, or it is the glutathione S transferase which is conjugating nitrosamines again gets altered. So this nitrosamine will actually increase. Nitrosamines normally increasing will cause bladder cancer. These two enzymes are actually decreasing the nitrosamines, one by binding them, the other by detoxifying them. If we are basically altering the function of these two enzymes, nitrosamine will rise, ultimately the bladder cancer incidence will also rise. So mutations in these two enzymes will cause the same situation. Just remember these two names, NAT and GSTM1, important MCQs. So apart from that, there are other different genetic conditions as well. Proto-oncogenes like RAS, tumor suppressor genes like P53, 21, 27, all these things are mugging up things. You can go through the books as well. So as I was just talking about many a times, what are the environmental factors and ultimately the other things. So these 4-amino biphenyl, arsenic, benzidine and beta-naphthylamine. These are the 4 major toxins present in the environment through the different kinds of work industries that I just told. It will be basically causing increase in the bladder cancer. Many patient comes to us, they say, I don't smoke, they say, I am not hypertensive, they say, I have done nothing. What's wrong with me that I got this particular cancer? Occupational history has to be asked. This occupational history might be very important to basically find out the cause. Smoking, as I just said, it's very important. Almost increasing 2 to 6 times. Now what is happening in the smoking? More the amount of smoke, more the number of years do we smoke, and also presence of a black tobacco with respect to a blonde tobacco. Black tobacco has more amount of aromatic amines, so that will again increase. So smoking is 100% thing that you are going to inquire, and in 90% of the situations you are going to get this as one of the causes of bladder cancer. Nutritional factors. Now this is very important. Those who are having more amount of red meat, more amount of the non-veg meats conditions, they are going to have increased chances of bladder cancers. Green leafy vegetables, fruits, antioxidants including the vitamin A, C, E, selenium, zinc, or it is also going to be the Mediterranean diet. These are actually protective. These are the ones which decreases the incidence of bladder cancer. Okay. Tea and coffee, they are also somewhat urothelial irritants. We have discussed in the normal prostate class that tea and coffee should be avoided because they were irritating the bladder. They actually also increase the chance of bladder cancer, not to that extent, otherwise everybody will stop having tea and coffee. It is just a slight amount of increase, particularly seen with the coffee drinkers who actually take it more than the moderate normal values. It's basically on a regular basis. This is interesting. One infection that is caused by the cystosoma hematobium. Again, a very important MCQ. Just it will write cystosoma hematobium. What does it cause? It causes squamous cell carcinoma of the bladder. So one infection condition which can also bring about bladder cancer is this. We discussed about genetics, we discussed about environmental factors, about smoking, but then infection can also be one such cause. Cystosoma hematobium. Apart from that, those who are basically on long-standing catheters, like for example, a CVA patient who is not able to void, he is on catheter for a long time. A patient who has underwent trauma, he is on catheter for a long time. Long time means around 2, 3, 4 years. These are patients who will have chronic infections, and they are actually at an increased chance of developing bladder cancers with respect to the others. I'm not saying everybody, but yes, a better increased incidence. Then there is one chemotherapy. We use chemotherapy to prevent one thing, and now we are developing the other thing. So it's cyclophosphamide which is used. It actually has one of the side effects that is going to cause bladder cancer. 2 MCQs from here. One is the name of cyclophosphamide. The other is, in fact 3. The other is the name of phosphoramide mustard. This is the main metabolite present in cyclophosphamide which actually brings about cancer chances. And the other third name, that is mesna. Mesna is 2-mercaptoethane sulfonic acid, and this mesna is the word that you need to remember. It is protective to this cyclophosphamide side effect of cancer. So 3 words from this particular slide. One, cyclophosphamide, the other, the metabolite of cyclophosphamide, which is phosphoramide mustard, and the one that is going to nullify the effect of it, it is mesna. Again, one very important thing, we give radiation to protect cancers. So prostate cancer, cervical cancer, we are giving basically radiation to that particular area. But long term, almost say around 10 to 15 years of giving the radiation, the patient might come to me with presence of hematuria. And we have to therefore acquire the entire history. That history becomes very important because they say that we just had this particular tumor, we are treated well, but now why this? So radiation can bring about bladder cancers on a long-term basis. So 15 years down the line, it was given and now it has developed a bladder cancer. Hereditary, yes, if a person, if a brother, dad, anyone is having a bladder cancer, the other one or the other sibling is having 2-fold increased chances of developing the same situation. So this was basically the etiology of a bladder cancer. Apart from that, good habits, including the increased amount of fluid intake, that will decrease the chances of infection, that will decrease the chances of any toxins to remain inside the bladder. More the toxins stay in the bladder, more they are having increased chance of attaching to the bladder wall and ultimately bringing about cancer. If the toxins are even coming and we are just flushing that off by the increased intake of fluid, it will definitely decrease the chance of bladder cancer formation. This again is a MCQ, that's why I have just added this particular thing, that it will be directly mentioned there. Alcohol increase or phenacetin increase will increase the chances of bladder cancer or not, it will not increase the chance. So it's not a very important line. for your particular situation, but for MCQs it's very important. So as I just said, there are many different types of enzymes which are there that actually brings about a normal epithelium, a urothelium, to undergo into either hyperplasia, dysplasia, and ultimately leading to the formation of cancer, which can be low grade or high grade, ultimately transferring themselves into a carcinoma in situ and then later into an invasive cancer, which if spreads undergoes a metastasis. So what are the different varieties of bladder cancer? 90% of bladder cancers are urothelial cancers, which we also say as transitional cell carcinoma. Why we say so? The bladder lining, the lining of the ureters, the lining of the urethra. So if we basically see this, the whole entire length of the ureter along with the PCS system, the whole of the bladder and as well as the urethra, the whole lining is actually urothelial lining. So any cancer which will develop in this particular lining will be a urothelial cancer. So that's why it is the most common variety, 90% of such. Apart from that, 5% varieties can be adenocarcinomas. Where do we find adenocarcinomas very commonly? It is in the colon, in the intestine. Here it is very less common, but if it's present, it is dangerous because it's aggressive in nature. Squamous cell carcinoma, again seen, as I just said, infections, schistosoma hematobium, long dwelling catheterizations, all that can increase, less than 1% situations, but it can be there as well. Apart from these three varieties, there are other varieties, which includes sarcoma, which includes small cell carcinoma. Small cell carcinoma is seen where normally? Yes, so small cell carcinoma is seen in lungs. So if suppose we do a tumor resection, we get a biopsy, it's a small cell cancer, we have to basically do a immediate HRCT thorax. We have to think about that this can be a metastatic condition. So small cell cancer is something which is very less common. If there, it is always requiring a post of chemo and radiation. It's an aggressive condition. So small cell cancer, sarcoma, nested variety, micropapillary variants, all these are also there, very less, but all these are those variants where we have to basically not give any other thing, straight away go for surgery because it's very aggressive in nature. So as I just said, urothelial cancers, also known as transitional cell cancers, are the most common type because it is the urothelial cells lining the entire tract of the kidney, ureter, bladder or urethra can actually get affected into these conditions. Squamous cell carcinoma, again found on the surface, but it's always invasive. It's always aggressive in nature. It's always aggressive. The other things is the sarcoma. Sarcoma, again a very less common variety. If it is present, it is again very dangerous. And sarcomas are normally is in the muscle cells. As we'll go forward, we'll understand that anything which has entered into muscle cells is obviously an advanced condition. So sarcoma, it will be taking place only in the muscle cells. It again comes out as an advanced condition itself. Adenocarcinoma, as I said, 1%, more common in colon cancers, again invasive in nature. Small cell cancers, whenever you are thinking about that, you have to think that you have to, it's very quick and you have to treat it immediately with the chemotherapy. Now, when we basically say that there is a transitional cell cancer, TCC, now this transitional cell cancers can be of two different varieties. One is the papillary, one is basically the NMIBC, which is called as non-muscle invasive bladder cancer. The other comes out to be as MIBC, which is the muscle invasive bladder cancer. Non-muscle invasive bladder cancers will have various varieties, PUNLMP, the low grade papillary tumors, the high grade papillary tumors, the CIS, and muscle invasive obviously is having these things. So this is a complicated slide. You have to remember these four names. That means PUNLMP, papillary urothelial neoplasm of low malignant potential, low grade papillary tumors, high grade papillary tumors. These are the most important things you need to remember about NMIBC, which is a non-muscle invasive bladder tumor. Muscle invasive bladder tumor is something which is having lamina propria or muscle propria invasion. So this is the same thing I have just entered here. It is the PUNLMP, low and high grade cancers, and CIS, which is basically the four most important varieties of NMIBC, non-muscle invasive bladder cancer. When I am saying non-muscle invasive bladder cancer, that means what? I think I have a picture for that. Yes. So this is the picture. As we just see here, there are various layers of the bladder when we do a cut section. Now in this cut section, if a tumor is only in this particular level which is attached to the mucosa, it is TA. That means it has actually not invaded into the inner walls. It is superficial bladder cancer. If it is basically entering into the lamina propria, this layer, it is the T1. Anything which actually enters into the muscle layer and ultimately beyond is the one that comes out in the muscle invasive bladder cancer. So you have to understand that any tumor which is up till the level of TA or T1 is very easily manageable. Apart from that, a T2, T3 and T4 is something which requires extensive management. So as I just said, low papillary PUNLMP. Now this PUNLMP is something which is basically, now this is a trigone. This is the trigone of the bladder where the PUJs are opening. So normally if a small growth is found at this trigone level, it is normally a PUNLMP. This is papillary low malignant tumor or tumor of low malignant potential. And this is something which is non-invasive in nature. So we will not require further therapy. Once it is treated, it is done. We just need to follow up the patient. So a single tumor here at the level of trigone. Forwards from this, solitary tumor at the level of trigone, something which is low proliferation, non-invasive. Finished. Low grade papillary tumors. Now this can actually take place anywhere. Tumors can be of two different varieties. One is papillary tumors with a small stalk. One is papillary tumors with a larger stalk, and the other comes out as a flat tumor. Now this larger stalk ones can be of low grade and it can be of high grade. I just discussed about PUNLMP and this is CIS. So three varieties are coming across. Tumors which are just hanging around without a stalk, it is basically PUNLMP. The one that is actually having a stalk and is actually papillary in nature, this is either a low grade or a high grade and can take place at any part of the walls in bladder. PUNLMP is a level of trigone, but that can be in any walls of the bladder. And the ones that are actually flat looking tumors are the ones which is actually CIS, carcinoma in situ. Now these are tumors which are very difficult to manage because normally we are not able to cut them because we cannot cut the entire wall of the bladder. It is a flat tumor which is like a carpet on the floor. Now you cannot remove the whole entire carpet, otherwise the whole floor will get scraped off. So that's why resection of this is very difficult. It is normally spreading like it is just going in a pagatoid fashion, entering either into the above ureters or into the urethra. So this carcinoma in situ has a pagatoid spread either above or below. So it is always aggressive and something which needs to be addressed very quickly with chemotherapy or early cystectomy. So it is basically always a high grade one. That can be low grade, high grade, the papillary ones, but CIS is always high grade. It is something which is actually having, this is not important, which is actually having a pagatoid spread either into the distal ureters or into the prostatic urethra. And endoscopically what you are going to see here. Now, if you see this particular thing, it's a cystoscopic view. You are not finding any abnormality, any growth which you can find out, we cannot. But when we see a blue light cystoscopy, there is an area which gets highlighted. This area is actually a carcinoma in situ. So a blue light cystoscopy has its role in carcinoma in situ because apart from that, if we are not finding any other things, we might miss even with our naked eyes. So carcinoma in situ is always having a worse prognosis. It is something, hello? It is something which has very high chances to progress into muscle invasive. So any tumor which is in this variety can enter into this variety as well. Chances of entering of this is the lowest, which is PUNLMP. Chances of entering of these three is highest, out of which this is less, this is more, this is highest. This is the simple way. So if you remember this gradation, you can actually easily simplify the whole bladder cancer as well, along with its treatment. Now, as I just said about the TNM classification, any tumor which is arising from the mucosa, it is the TA which is non-invasive. A one that is basically having just a small stalk It is something which is entered into the subepithelial connective tissues, which is including the lamina propria. As I just showed that particular image, it was better image to understand. This is TA, which is something only arising from the mucosa. T1 is basically entering into lamina propria. T2 is something which is entering into the muscle layer. Now this T2 is further divided into T2A and T2B. T2A is only the superficial muscle is affected. T2B is deeper layers of muscles are also getting affected. T3 is something which has entered into the perivesical tissues. Perivesical tissues means just outside the bladder wall as well. Now this perivesical tissues can be microscopic or it can be macroscopic. So T3A, T3B. And then comes out T4. T4 is something which has entered into the adjacent organs. Now this adjacent organs can be the prostate, it can be the seminal vesicles, and if it's a female, it can be basically the uterine areas, the cervix, the vagina, anything. So it's a simplified view of how to stage the disease. Now we'll again go back to this. So T1 is something lamina propria, T2 is muscularis, which is having superficial as well as deep. T3 is basically perivesical, microscopic, macroscopic, and T4 into the adjacent organs, prostate, seminal vesicles, uterus, vagina, any of the areas. So this is the simplified way by which you can remember the staging. In a staging, we always have not only the T stage but also the N stage. So the most common areas where the lymph nodes are going is actually the pelvis, pelvic group of lymph nodes. And this pelvic group of lymph nodes are basically having the iliac group of lymph nodes, it is having the obturator group of lymph nodes. So these two important lymph nodes also sometimes needs to be taken out in patients who are having muscle invasive bladder cancer. So a patient who is just having a single regional lymph node is N1 and who is having a multiple lymph nodes is N2. So any lymph node which is just limited to the pelvis, if it's single N1, if it's multiple N2, and any lymph node which is just going above that, that means the common iliacs, it is N3. Distal metastasis we all know is there. So till now we have discussed about the etiology, we have discussed about what are the different types of bladder cancer, and then we have discussed about what is the staging. Now comes is the fact that, okay, after all this, what is the patient going to come to us? So the patient normally comes to us with hematuria. This hematuria can be a gross hematuria, can be a microscopic hematuria. Gross hematuria is something which is visible to the eyes and the patient will run off and ultimately come to us and say, sir, what is happening? I am passing blood in urine. Now this is normally painless, but if it is associated with dysuria, with irritative symptoms, it might be having a super added infection to it. Bladder cancers are normally painless hematuria. Apart from that, what are the other symptoms that we do find? Now the tumor is something which is present in the walls. Anything in the wall will ultimately irritate that wall and ultimately will bring about irritative symptoms. We discussed about prostatic irritative symptoms. The similar kind of symptoms are there. Patient will have increased frequency, will have urgency, will pee time and again and say that even when we go to the washroom, we are not able to pass urine well. So these type of irritative symptoms might be associated, particularly tumors which are below the level of trigone. Tumors which are above the level of trigone will not have irritative symptoms. Below the level of trigone will be near to the prostate and they will have irritative symptoms more than any others. So irritative symptoms including frequency, feeling of need to urinate throughout the times and ultimately not able to pass urines are also there, apart from passing of blood clots and hematuria. If a patient is actually having other symptoms, which includes abdominal pain, which includes jaundice, which includes shortness of breath, which includes bony pain, you also need to think that there might be, that this is an advanced tumor that we are dealing with and it can be metastatic in nature. So yes, we talked about urinary complaints, we talked about low back pain. Any tumor is always going to be associated with weight loss and decreased appetite along with fatigue, any tumor. So that is a common symptom. When we have to fill up pages, we obviously write these two symptoms as well. Bone pain and swollen feet. So any tumor, three things are basically required. One is we need to diagnose the situation. Then we need to basically have a local extent of the situation. And then we need to have a systemic staging of the situation. After the systemic staging is done, we thereafter go for the treatment. So for a diagnosis, we will be basically discussing that how we are going to diagnose. First is obviously a clinical examination. Second is certain investigations including the urine analysis, including certain blood investigations like the urea, creatinine, etc., including the CBC. All these things are there. What are you going to expect in a CBC? Hemoglobin drop. What are you expecting in case of a urea creatinine? It will be normal. Apart from patients who are having tumors that is blocking this ureters. If a tumor, suppose if this is the bladder and these are the two ureteric orifices, a tumor is there which has occluded the ureteric orifice. That means it is going to obstruct the kidney and they can be landing with increased creatinine values. They can be having the swollen feet that I just showed in the last one. So these tumors are the ones which will be basically having chances of increased creatinine. So that is CBC, urea creatinine, urine analysis. What are you going to expect? It is presence of RBCs. One situation where obstructive uropathy has taken place, proteinuria, etc. can come across. Apart from that is the imaging studies. So imaging studies is including the ultrasonography, a simple basic test which you are going to advise the patient. And these are certain other tests which are normally not done as a diagnostic test, it's more of a therapeutic test. Cytology is very important for CIS patients. I just said that CIS patients, you will not find tumors, you will not find either in the CT scan or USG, still patient is having symptoms. So you have to send a urine for malignant cytology. And if the urine for malignant cytology comes out positive, a very strong indication that the patient is developing CIS. If a patient is also having prostatic symptoms, irritative symptoms, we might need to require a prostatic fossa biopsy or an examination under anesthesia. Suppose a USG gives a picture of a tumor which is more than 3 centimeters. In that situation, we need to go for a CT or a MRI to basically know what is the extent of it, because through a CT and MRI, we can have a basic idea whether it is going and invading the muscle or perivesical area, and a better local staging can be done. So first, as I said, CT scan and then comes out is the regional staging. Now what is regional staging? We diagnosed that yes, there is a bladder cancer, but now we need to know the lymph nodal status. We cannot find the lymph nodal status in a USG. So lymph nodal status can be found out either in a CT or a MRI. Also through the CT and MRI, we are having a systemic staging that can be done. CT thorax, MR, PET scan. These are just bookish. And systemic staging, whenever a patient is having shortness of breath, what are you suspecting? You are suspecting that they might be having a advancement to the lungs. So these are certain investigations including CT, chest films, which can be helping us. A patient who is having a bone pain will be basically having a bone scan that is done, which will be having a MR that is done. Liver, patient is having jaundice, a liver scan or a CT and a PET MRI can be helpful. So now this is a USG picture of a bladder cancer. Can you find any abnormality in this area? This is the abnormality. The whole wall is normal. Apart from that, there is a small elevation in the right lateral wall of the bladder. This basically thing is a typical picture of a bladder cancer. If we go for an eye view of the similar situation, we will find a filling defect or we will find basically something that is getting highlighted. This is the entire bladder filled with the dye, and this is a tumor which has not taken up the dye, rather it is actually acting as a filling defect, and so we can see and diagnose the thing. But always a CT is a better one to stage the disease and to assess the pelvic lymph nodes, to assess any metastasis to the liver, any metastasis to the lungs, any metastasis even to the kidneys and the upper ureter as well. This is a CT picture where we can see again the same tumor in a better way. And this particular whole situation, these are two different ones. These are multiple tumors, 1, 2, 3, which has filled the entire bladder. And this is one also such situation where we can see a peripheral calcification. Now see, this is basically enhancing areas. So these tumors have actually developed peripheral calcification. Development of peripheral calcification is good. Normally these are in single tumors and have a better prognosis. MRI is something which is done if CT is not possible. So you all know that where a patient is not having an increased creatinine or any other things, we cannot go for a CT scan, we have to go for a MRI. PET CT is the basic test for systemic staging. So now, if suppose we have done all the situations, we have found out that there is a basic tumor. Now how are you going to deal with this? surgery is the basic thing which is always required. We do not require a pre-operative biopsy for this cancer. Most of the cancers like prostate cancers, bladder cancers, they require a pre-operative biopsy. But in these tumors, we can directly go for the surgery based on the imaging investigations. Suppose we are not able to find out anything, then what you are going to do, patient is still having hematuria. In that situations, we have to go for a endoscopy, which is basically through the urinary tract. And this endoscope through the urinary tract is called as cystoscopy. So a cystoscopy is actually coming out as a gold standard investigation, always invasive in nature. So it is always going to be a last investigations if we are not able to find out anything. Before the surgery, we are definitely going a cystoscopy, but ultimately as a pre-operative method, we are going to do it only if we are having any doubt in the diagnosis or it is basically not able to diagnose at all. So this is the way we do a cystoscopy. It's a scope that is entered through the lumen of the penis or through the female urethra, and ultimately transversing through the entire urethra, we are directly visualizing the entire walls of the bladder. This is the light which will actually help us to show the entire thing. So this is a cystoscope that is there. And how does the tumor look like in the cystoscope? This is the tumor which looks like in a cystoscope. Can you identify what is this structure? This is basically the VUJ that I was drawing. This small opening of the ureter. So basically this tumor is lying very close to the ureteric orifice. And as I was just saying, the CIS is better diagnosed on a blue light cystoscopy. As you can see, this was normal. Ultimately, it has lit up. So after we have diagnosed the situation, now comes what are you going to do? I said it's a surgical disease. We have to do a surgery. We have to resect out the tumor. So the most common thing that we basically do is actually, whether if it is a localized disease, endoscopic management, which is in the form of TURBT, transurethral resection of the bladder tumor. It is the most important and the gold standard thing that we are going to do. And once we have done the transurethral resection, based on the biopsy, we can also give intravesical chemotherapy depending upon what is the stage of the disease. If the stage of the disease is TA, no therapy is required. It's just the simple follow-up. If the stage is T1, then we have to give a chemotherapy, which we'll discuss is either in the form of BCG or it is chemotherapy in the form of gemcitabine, docetaxel, etc. If suppose this is a focal disease, then just TURBT is good enough, followed by intravesical therapy. If it's a diffuse disease, what are we thinking about diffuse disease? That is CIS. If it's a diffuse disease, we cannot resect the tumor. As I said time and again, we cannot remove them. Then we have to immediately start with the BCG immunotherapy. Suppose the BCG immunotherapy is not functioning, in that situation we have to remove the entire bladder. Okay. So basically this was removal of only the tumor followed by the therapy, and if it's a diffuse disease like CIS, it is the immunotherapy which is started first, and thereafter if it is not getting controlled, it is the early cystectomy which has to be done. Suppose a patient is not only having CIS but also having a other tumor as well. So there is a flat carpet, apart from that one wall is showing a papillary tumor as well. In that situation, what is the treatment? In that situation, you will do that particular resection of the tumor and then you will start with the BCG immunotherapy. Again, same situation, not getting controlled, just remove the bladder, which is early cystectomy. So this is the simple basic way how we are going to treat a focal disease, CIS, and a condition where both the things are concurrently seen. So this is the way we are basically doing the CIS. This is the tumor here, and we are taking a special instrument which is a resectoscope, and through the resectoscope, bypassing an electric current, we are taking the entire tumor out. Always remember that once we are taking the entire tumor out, we are taking a deeper biopsy as well. So we are taking two separate biopsy. One is the entire tumor that is resected, and one is a layer deep to that, which is the deep muscle, because we need to know what is the extent of the disease. If suppose we find that the tumor is so extensive, we are not able to cut through, then in that situations, what we are going to do, we'll just take a small section of the tumor, which is called as TUR biopsy, and based on that, we can go for a cystectomy. And suppose a patient is actually having an inoperable tumor. Inoperable tumor means that the patient is already having a metastasis, although the tumor inside the bladder was small. patient's age is 80 years. In that situation, patient cannot be having a radical cystectomy can be done. So we'll just resect out the tumor as a palliative measure. These are basically done always under a GA. Regional anesthesia is always done with the obturator block. And as I just said, a tumor along with the deep portion with the muscle is always taken out. So TURBT is that. Partial cystectomy, where we need to do, it's a typical indication adenocarcinoma of the prostate, when of the bladder. When we are basically finding that in the dome, a partial cystectomy is indicated. Apart from that, not. And as I said, invasive bladder cancer, any tumor which is above T2 is taken as muscle invasive bladder cancer. What is the treatment of a muscle invasive bladder cancer? It is always going to be a radical cystectomy. So that means the entire bladder has to be removed. In that, it's the gold standard. Only patients in where we are basically finding that they are not able to or they are not fit enough for radical cystectomy, we are going for a bladder preservation therapy, where radiotherapy, chemotherapy and TURBT are going simultaneously. This is the basic thing. So if we are removing a bladder, what are the things we are removing in that? So basically we are removing the entire bladder, we are removing the prostate as well, and then we are basically having the iliac vessels out here, we are having lymph nodes at that particular level, so we are removing that particular thing as well. So the entire surgery is called as a radical cystectomy with a bilateral pelvic lymph node dissection. Now if we have removed the bladder completely, patient has to pass urine through some area, otherwise how will they pass urine? So we basically reconstruct a bladder through the segment of an intestine, which is basically exteriorized through the abdomen in the form of a stoma called as a ileal conduit. So this is the whole entire thing, as we say. This bladder was removed, the two ureters coming from the kidney, they are thereafter joined through a segment of the intestine. This is basically the exterior portion through which the urine is going to come out. So this now becomes the neobladder. This now becomes the part, this is the basic bladder which is actually going to act. We have made it through the help of our intestine. It is called as ileal conduit, and this is a permanent thing. We are not able to reconstruct the bladder like that. The other way that is going to be there, for suppose a younger patient, they will say that I will not be able to keep a stoma the entire life. So in that situations, if a patient is having a treatment where the prostatic fossa was not involved, a neobladder is created. So we can see a segment of the intestine, and this is also a segment of the intestine itself which has been made globular. So a very large segment of intestine is taken and a whole entire bladder is reconstructed, which is known as neobladder. So there are two methods of diversion after the cystectomy. This diversion is a ileal conduit which is having a permanent stoma outside the bladder the entire life, and this is basically passing through the same area as normal, and this is called as a neobladder. The only disadvantage with neobladder is that they basically develop retention time and again, and they have to perform CIC or a catheterization to take out the urine. Other non-surgical approaches, as I just said, it's including the chemotherapy, and this chemotherapy is not actually coming out as a primary treatment, it is post-surgery or as a neoadjuvant therapy. So if a patient is already having a large tumor, we need to downstage the tumor. In that situation, we are going to basically give it. Or suppose the pelvic lymph nodes comes out positive, the basic tumor biopsy comes out very high. In that situations, we can give a intravesical chemotherapy. Now, the most common intravesical chemotherapy is not the three things. It is actually the BCG. BCG therapy is very common. It's done here as well if you have attended the emergencies. So BCG therapy is basically having a protocol. It is done after the surgery, 2 to 3 weeks later. First is the induction cycle of 6 doses, weekly apart. Thereafter 6 monthly intervals, it will be having 3 doses. That will be 3 maintenance cycle. So the entire course comes out 2 years. First 6, then 3, then 3, then 3. It's 6 monthly intervals. So this is the way the BCGs are actually given. Now this BCG therapy, we just need to remember one very important thing. A patient who is undergoing BCG therapy, they will come after that, they will say that I am having severe level of burning sensation, severe dysuria, passing frequent urine. So this is basically a side effect of the BCG therapy, which is actually called as bladder irritability. Now, sometimes the patient may also develop systemic TB, fever. In that situation, we need to stop the drug. We need to start with the tuberculosis. BCG is nothing but ultimately the Bacillus calmette-guerin. So this is basically TB bacteria, and this TB bacteria is acting as a chemotherapy in this particular situation. I have already explained this particular thing. It's a 6 induction cycle, 6 weeks gap, and thereafter it is going to be at 6 monthly interval for the next 2 years. Actually, this is the old guidelines. The new guideline says 2 years are good enough. Now for very small tumors, if the tumor has been resected, 6 months interval down the line, you did a cystoscopy again to see whether there is recurrence, you find that there is a recurrence again. It's a very small recurrence. In that situation, you can just burn that tumor with the help of lasers, which can be either argon laser, Nd:YAG lasers, although this is not so easily available. At higher centers we are having it. The disadvantage is that the entire tumor gets burned. We are not getting any tissue and we are not able to send any biopsy further. Radiotherapy actually has a role only in patients who are having palliative measures. A patient who is having muscle invasive bladder cancer, frail patient, old age patient, we cannot do anything about it. What we are going to do, it's actually a radiation therapy. Again, a patient who comes to us and ultimately we underwent a cystectomy but actually has a local recurrence. We cannot do a surgery in that patient, again a radiotherapy can be given. So this is the basic thing. Chemotherapy I have already discussed, it's basically is a neoadjuvant setting or as an adjuvant setting. Neoadjuvant is something for downstaging the tumor, any tumor which was found to be inoperable. Suppose a patient comes and ultimately the CT scan says it's completely stuck up with the pelvic wall. So we are not able to do the surgery at that point of time. If we downstage the disease, the pelvic wall, the tumor shrinks from the pelvic wall, we are now able to take out the tumor. So the downstaging is sometimes very important. And sometimes it has been seen that the pelvic lymph node comes out positive or there is metastatic settings, then adjuvant settings it can be given as well. The most important agent that we give is actually the cisplatin. The second important agent is the gemcitabine. So these two names are there. But nowadays, one very important drug that has come across is a docetaxel. So 3 names: cisplatin, gemcitabine and docetaxel. So as I already said, how to prevent the whole situations: have less amount of the non-veg or red meat diet, have more amount of green leafy vegetables and fruits, something of antioxidants varieties A, C, E, selenium, zinc, less of tea and coffee, more of green tea, and thereafter it is going to be more of fluid intakes as well as acidification of urine. First we basically did the bladder cancer, how to diagnose the bladder cancer. The etiology was there: genetics, smoking, inflammation, infection, radiotherapy, hereditary. Finished. The different types of tumors: transitional cell cancer, adenocarcinoma, squamous cell cancer, small cell cancer, sarcoma. It was the different types. The 3 different varieties: papillary tumors, high grade, low grade, PUNLMP, which is non-muscle invasive, muscle invasive bladder cancers. Coming to symptoms, it's hematuria and hematuria. Apart from that, irritative voiding symptoms. Coming to investigations, CBC, urea, creatinine, CT, USG. If a tumor more than 3 centimeters, CT and MRI. If a tumor suspects to have systemic staging, a PET CT. Coming to the surgery, if it's a localized disease, TURBT is the most important thing. If it's a CIS, immunotherapy with the help of BCG. If not getting control, cystectomy. Coming to the fact it's muscle invasive, the entire bladder needs to be removed. If we are removing the bladder, we need to reconstruct either by the ileal conduit or by the neobladder. If a tumor is something which is non-resectable, chemotherapy as well as radiotherapy has a role. Post TURBT, if the tumor counts to have a higher values, BCG immunotherapy, 6 induction cycles, 3 maintenance cycles. That's the thing. Thank you.